A 60-year-old male with a history of hypertension, hyperlipidemia, and smoking presents with sudden onset left-sided weakness, slurred speech, and facial droop. The symptoms have been ongoing for 45 minutes. What is the most likely diagnosis and what are the immediate management steps? Answer: the most likely diagnosis is an ischemic stroke, which occurs due to a blockage in the blood vessels supplying the brain, leading to lack of oxygen and nutrients to the affected brain tissue. The patient's risk factors, including hypertension, hyperlipidemia, and smoking, significantly increases risk for a stroke. The sudden onset of left-sided weakness, slurred speech, and facial droop are classic signs of a stroke, particularly involving the right hemisphere of the brain, which controls movement and speech on the left side of the body. Immediate management steps include rapid assessment. It is crucial to confirm that the symptoms are due to an ischemic stroke and not another condition like a transient ischemic attack TIA or a hemorrhagic stroke. Use of the NIH stroke scale can help quantify the severity of the symptoms. Time is brain. The goal is to intervene as quickly as possible, ideally within a 4.5 hour window from symptom onset for potential thrombolytic therapy. The patient should receive a CT scan of the head to rule out a hemorrhagic stroke and to evaluate the extent of ischemia. Intravenous thrombolysis. If the CT scan shows no hemorrhage and the patient is within the therapeutic window, alteplase or PA may be administered as thrombolytic therapy to dissolve the clot and restore blood flow. Mechanical thrombectomy. For patients with large vessel occlusion, endovascular thrombectomy can be considered up to 24 hours after symptom onset, depending on the extent of brain injury, as assessed by advanced imaging, CT perfusion, or MRI, monitoring and supportive care. Continuous monitoring of vital signs, blood glucose levels, and oxygen saturation is essential. Antiplatelet therapy, aspirin, may be started to prevent further clot formation. Timely intervention can significantly improve the patient's outcomes, but the most critical factor in management is acting swiftly within the established timeframes. Explain the first-line treatment options for managing osteoarthritis OA and how do non-pharmacologic interventions compare to pharmacologic interventions? Answer: osteoarthritis OA is a degenerative joint disease characterized by the breakdown of cartilage and changes in the underlying bone. Management of OA involves both non-pharmacologic and pharmacologic interventions. Non-pharmacologic treatments are typically the first-line approach and include weight management for weight-bearing joints, physical therapy to improve range of motion and strengthen muscles, and lifestyle modifications like exercise. Occupational therapy may also help in adapting daily activities to reduce joint stress. Pharmacologic treatments include acetaminophen, preferred for mild to moderate pain, NSAIDs, non-steroidal anti-inflammatory drugs, used for pain and inflammation, but should be used cautiously due to potential gastrointestinal and renal side effects. Topical analgesics, such as capsaicin or diclofenac for localized pain. Intra-articular corticosteroid injections, considered for short-term flare-ups in specific joints. Hyaluronic acid injections may provide symptomatic relief by improving joint lubrication. In terms of efficacy, non-pharmacologic interventions like physical therapy and weight loss often show more sustainable long-term benefits compared to pharmacologic treatments, which provide more immediate but temporary relief. Surgical interventions, including joint replacement, are considered for advanced OA that is unresponsive to other treatments. Mr. Harris is a 72-year-old male with a history of hypertension and diabetes. He presents with progressive fatigue, swelling in his legs, and reduced urine output. His lab results show elevated serum creatinine and proteinuria. What is the most likely diagnosis and how should Mr. Harris be managed? Answer: given Mr. Harris' history of hypertension, diabetes, and the clinical signs of fatigue, swelling, and reduced urine output, the most likely diagnosis is chronic kidney disease (CKD), possibly due to diabetic nephropathy. Diabetic nephropathy is a common cause of CKD and is characterized by proteinuria and a progressive decline in renal function. Management should focus on blood pressure control, targeting a goal of 138 mHg with ACE, inhibitors or angiotensin I receptor blockers ARBs to reduce the risk of progression, glycemic control, tight control of blood glucose levels to slow the progression of diabetic nephropathy, dietary modifications. A low-protein diet may help reduce kidney workload, management of edema, use of diuretics such as furosemide to manage swelling, monitoring renal function, regular monitoring of serum creatinine, glomerular filtration rate, GFR, and urinary protein levels. If necessary, consideration for renal replacement therapy. Dialysis should be discussed once CKD progresses to stage 5. What are the diagnostic criteria for gout, and what is the first-line treatment during an acute flare? Answer: gout is an inflammatory arthritis caused by the deposition of monosodium urate crystals in joints. The diagnostic criteria include clinical presentation, sudden onset of severe pain, redness, and swelling, most commonly affecting the first metatarsophalangeal joint, podagra, synovial fluid analysis, the definitive diagnostic test showing needle-shaped crystals that are negatively bifringent under polarized light, serum uric acid. Hyperuricemia is common in gout but is not diagnostic alone, since not all individuals with elevated uric acid develop gout. Imaging, X-rays may show tophi or joint damage in chronic cases. The first-line treatment for an acute gout flare involves NSAIDs, indomethacin for pain and inflammation, colchicine, which can be used within the first 24 hours of symptoms for rapid relief, corticosteroids. Oral or intra-articular injections can be considered when NSAIDs and colchicine are contraindicated or ineffective. Explain the staging of chronic kidney disease (CKD) and the key principles of its management. Answer: CKD is staged based on glomerular filtration rate (DFR) and the presence of proteinuria. Stage 1: GFR 90 ml on 0.73 m with evidence of kidney damage, e.g. proteinuria. Stage 2: GFR 6089 ml on 0.73 m with evidence of kidney damage. Stage 3: GFR 4559 ml on 0.73 mm. Stage 3: GFR 3044 ml on 0.73 m. Stage 4: GFR 1529 ml on 0.73 mm. Stage 5: GFR 15 ml on 0.73 m. End-stage kidney failure. Management involves blood pressure control. Aim for 138 mmHg, primarily using ACE inhibitors or ARBs. Glycemic control. In diabetic patients, strict control of blood sugar to delay progression. Dietary interventions. Low-protein diet in later stages to reduce kidney burden. Management of comorbidities. Control of lipids, anemia, and bone mineral disorders. Dialysis or kidney transplantation considered when CKD reaches stage 5. What is the role of early disease-modifying enterohepatic drugs, DMARDs, in the management of rheumatoid arthritis, RA, and what is the recommended approach for initiating therapy? Answer: early initiation of DMARDs in rheumatoid arthritis, RA, is crucial to prevent joint damage and improve long-term outcomes. Methotrexate is considered the first-line DMARD due to its proven efficacy. Other DMARDs include hydroxychloroquine, sulfasalazine, and leflunomide. The general approach includes early diagnosis. Symptoms such as morning stiffness, joint swelling, and symmetrical joint involvement are classic signs. Initiation of DMARDs. Once RA is suspected, DMARD therapy should begin as soon as possible, ideally within 3 months of symptom onset. Biologic agents. If DMARDs are inadequate, biologic agents like TNF inhibitors, e.g. etanercept or IL-6 inhibitors can be considered. Regular monitoring for side effects such as liver toxicity with methotrexate is required. What is the clinical significance of hyperkalemia, and what is the first-line treatment approach in an acute setting? Answer: hyperkalemia is a potentially life-threatening electrolyte disturbance commonly associated with renal failure. Medications e.g. ACE inhibitors, potassium-sparing diuretics, and metabolic acidosis. Serum potassium levels above 5.5 mcl are considered elevated. The clinical significance lies in the risk of cardiac arrhythmias, including ventricular fibrillation and asystole, which can occur with severe hyperkalemia, typically above 6.5 mcl. First-line treatment includes calcium gluconate to stabilize the cardiac membrane and reduce the risk of arrhythmias, insulin and glucose to shift potassium back into the cells, sodium bicarbonate if metabolic acidosis is present, diuretics e.g. furosemide to promote potassium excretion in the urine. In severe cases, hemodialysis may be required. At what age should osteoporosis screening begin, and what are the key preventative strategies for at-risk individuals? Answer: screening for osteoporosis should begin at age 65 for women and 70 for men, according to the U.S. Preventive Services Task Force. Women under 65 and men under 70 may be screened earlier if they have risk factors such as family history, low body weight, smoking, alcohol use, or fractures. Preventative strategies include calcium and vitamin D supplementation to support bone health, weight-bearing exercise, e.g. walking resistance training to strengthen bones, pharmacologic treatment for high-risk individuals such as bisphosphonates, e.g. alendronate and denosumab, lifestyle modifications, avoidance of smoking and excessive alcohol consumption. What are the diagnostic criteria for systemic lupus erythematosus, SLE, and what is the role of autoantibodies in confirming the diagnosis? Answer. Systemic lupus erythematosus, SLE, is diagnosed based on the presence of clinical symptoms and autoantibody tests. The American College of Rheumatology (ACA) criteria for diagnosis include symptoms such as mallow rash, photosensitivity, oral ulcers, arthritis, and renal involvement. The role of autoantibodies includes antinuclear antibody (ONA), positive in 95% of SLE cases but not specific, anti-DNA, specific for SLE, present in 70% of cases, anti-Smith SM, highly specific for SLE, but less common, anti-ROS and anti-LASB, associated with SLE and can help diagnose subtypes like subacute cutaneous lupus. Treatment involves immunosuppressive medications, including hydroxychloroquine and corticosteroids, depending on disease severity. What are the common types of kidney stones and how should they be managed based on their composition? Answer. Kidney stones, nephrolithiases, can be classified based on their composition, calcium oxalate, the most common type often linked to dehydration or hypercalciuria. Management includes increasing fluid intake, thiazide diuretics to reduce calcium excretion, and dietary modifications. Struvite, associated with urinary tract infections and alkaline urine. Treatment involves antibiotics and often surgical removal as these stones are large and can cause obstruction. Uric acid, formed in acidic urine, often seen in patients with gout or hyperuricemia. Management includes alkalinizing the urine with potassium citrate and controlling uric acid levels. Cystine, rare and due to a genetic disorder. Treatment includes alkalinizing the urine, increased hydration, and tiaprenin to prevent stone formation. If stones are large or symptomatic, interventions like lithotripsy or ureteroscopy may be necessary. Psoriasis is a chronic inflammatory skin disorder characterized by rapid skin cell turnover. What are the key differences in the pathophysiology of psoriasis and eczema, and why is it critical to differentiate between these two conditions when choosing a treatment plan? Answer. Psoriasis and eczema, atopic dermatitis, are both inflammatory skin conditions, but their pathophysiology differs significantly. Psoriasis is primarily a T-cell mediated disorder where an overactive immune system leads to the rapid turnover of skin cells. This leads to thick, scaly plaques commonly on the elbows, knees, and scalp. The disease is often associated with systemic inflammation, and patients may experience comorbidities such as psoriatic arthritis. The primary treatment goals focus on reducing inflammation and slowing skin cell turnover. Topical corticosteroids, vitamin D analogs, and systemic therapies like biologics, e.g. TNF inhibitors, are commonly used. Eczema, on the other hand, is often associated with an allergic response and itching response. This results in dry, itchy, and inflamed skin, typically on flexural areas such as the wrists, elbows, and behind the knees. The treatment involves managing the dryness and inflammation through moisturizing, avoiding triggers, and using topical steroids or calcineurin inhibitors. Why it is critical to differentiate. Differentiating between psoriasis and eczema is essential because the treatment strategies vary significantly. Psoriasis often requires agents that target the immune system, such as biologics or immunosuppressants, whereas eczema treatment focuses more on symptom control, moisturization, antihistamines, and avoiding triggers. A 35-year-old at HIV-positive patient presents with fever, night sweats, and cough productive of green sputum. Chest X-ray reveals a right upper lobe consolidation. What are the most likely opportunistic infections associated with HIV that can present in this manner, and what is the first-line treatment for these infections? Answer. The most likely opportunistic infections in HIV-positive patient with fever, night sweats, cough, and a consolidation on chest X-ray include pneumocystis, gyrovcia pneumonia, PCP. A common opportunistic infection in HIV patients with a EN below 200 cell. Patients often present with a dry cough, shortness of breath, and fever. The first-line treatment for PCP is trimethoprim sulfamethoxazole (TMMX). Bacterial pneumonia, G. Streptococcus pneumoniae. Patients with HIV are also at an increased risk for bacterial infections due to immunosuppression. The management includes empiric antibiotics, such as ceftriaxone or levofloxacin, depending on the local and tubergram. Tuberculosis (TB). HIV-positive patients are at increased risk for TB and are often present with pulmonary symptoms. Treatment involves a combination of rifampin isoniazid, pyrazinamide, and ethambutol. If the patient's CD count is low, PCP is a high priority. Treatment for PCP should begin promptly while awaiting culture results. Mr. Stevens, a 42-year-old male, presents with an itchy rash on his hands and forearms. He reports frequent contact with cleaning products at his workplace. Upon examination, the rash is erythematous with well-defined borders and a history of recent exposure to chemicals. What is the most likely diagnosis and how would you manage this condition? Answer: the most likely diagnosis is contact dermatitis, specifically irritant contact dermatitis, which is often triggered by exposure to chemicals or physical irritants. This is common in individuals who frequently handle cleaning products or other harsh substances. Management includes avoidance of the irritant. The patient should be advised to limit exposure to cleaning products or use protective gloves. Topical corticosteroids. To reduce inflammation, a medium-potency steroid like hydrocortisone 2.5% or triamcinolone can be applied to the affected areas. Emollients. Regular use of moisturizing creams can help restore the skin barrier and prevent further irritation. Education. The patient should be educated on the importance of wearing gloves and other protective measures to prevent future outbreaks. If the condition becomes chronic or severe, referral to a dermatologist for patch testing may be required to identify specific allergens or irritants. What is the mechanism of action of protease inhibitors, PIS, in the treatment of HIV, and why are these agents critical in preventing the development of HIV resistance? Answer: protease inhibitors, PIS, work by inhibiting the Chivalrone protease enzyme, which is responsible for cleaving the viral polyproteins into their functional components. This step is essential for the maturation of new virions. By blocking this process, PIs prevent the formation of infectious viral particles, thereby reducing viral load in HIV-infected patients, while critical in preventing resistance. PIs are part of highly active antiretroviral therapy, HAART, which typically combines multiple classes of drugs to achieve maximal viral suppression. This multi-drug approach helps to prevent the development of drug-resistant HIV strains, as the virus is less likely to develop resistance to multiple drugs simultaneously. If resistance occurs, however, treatment options become limited, emphasizing the importance of adherence to the prescribed regimen. A patient presents with a ring-shaped rash with raised, scaly borders on the arm, consistent with tinea corporis. What is the first-line treatment for this fungal infection, and how can you differentiate between tinea corporis and other dermatologic conditions such as eczema or psoriasis? Answer: tinea corporis, also known as ringworm, is a superficial fungal infection caused by dermatophytes. The classic appearance is a ring-shaped lesion with raised, scaly borders and a clear center. First-line treatment: topical antifungals such as terbinafine, clotrimazole, or miconazole are typically used to treat tinea corporis. In more severe cases or extensive infections, oral antifungals like griseofulvin or terbinafine may be necessary. Differentiating from other conditions, eczema typically presents with erythematous itchy patches but without the characteristic ring-shaped border. Eczema is also more likely to occur in flexural areas and lacks the raised edge seen in tinea corporis. Psoriasis may present with scaling, but it usually involves well-defined plaques with silvery scales and is often found on extensive surfaces, unlike the central clearings seen in tinea corporis. A KOH preparation, potassium hydroxide, or fungal culture can help confirm the diagnosis by identifying fungal elements in the skin scraping. A 45-year-old male presents with jaundice, fatigue, and dark urine. He has a known history of hepatitis B infection. Laboratory tests reveal elevated liver enzymes and a positive HB with a high viral load. What is the significance of the HB and what are the treatment options for this patient? Answer: HB hepatitis B antigen is a viral protein that appears during the replication of the hepatitis B virus HBV and is an indicator of active viral replication and high infectivity. A positive HB along with a high viral load suggests that the patient is in the active phase of infection and there is a higher risk of transmission. Treatment options: antiviral therapy. The goal of treatment in chronic hepatitis B is to reduce viral load, suppress liver inflammation, and prevent progression to cirrhosis. First-line antiviral agents include tenofovir, either disoproxil fumarate or alafenamide, or entecavir. Monitoring. Regular monitoring of liver enzymes alt-ast, viral load each year, and liver function is necessary to assess the effectiveness of therapy and detect any signs of resistance or complications like hepatocellular carcinoma. In some cases, interferon-based therapy may be considered, but it is less commonly used due to its side effect profile. MS Andrews, a 30-year-old woman, notices a new mole on her back that has recently become darker and asymmetrical with irregular borders. She is concerned about skin cancer. What are the key features of melanoma that differentiate it from benign nevi, and how would you manage this patient? Answer: the key features of melanoma that differentiate it from benign nevi include asymmetry. One half of the mole does not match the other half in shape or color, irregular borders. Melanomas typically have jagged, blurred, or irregular borders, unlike the smooth borders of benign moles. Color variation. Multiple shades of brown, black, or even red and white within the same lesion diameter. Melanomas are often larger than 6 millimeters in diameter. Evolution. Any change in size, shape, or color of a mole is concerning for melanoma. Management involves referral to dermatologist. A full skin examination and excisional biopsy are necessary for diagnosis. If melanoma is confirmed, the stage of the melanoma using the Clark level and Breslow thickness determines the treatment approach, which may include surgical excision, sentinel lymph node biopsy, and possibly immunotherapy or targeted therapies. A 60-year-old diabetic male presents with fever, chills, hypotension, and a tachycardia of 120 beats per minute. His laboratory tests reveal elevated white blood cell count, and blood cultures are positive for Staphylococcus aureus. What are the criteria for diagnosing sepsis, and what is the first-line treatment approach? Answer: sepsis is a systemic inflammatory response syndrome (SIRS) caused by an infection, often leading to organ dysfunction. The diagnostic criteria for sepsis include systemic inflammatory response syndrome (SIRS) criteria: fever 38.3 deg or hypothermia 90 beats per minute, tachypnea respiratory rate 20 breaths per minute or POCO 12,000 dil or 4,000 dil. Organ dysfunction. This includes hypotension, decreased urine output, altered mental status, and elevated lactate levels. Treatment: antibiotic therapy. The first-line treatment is empiric broad-spectrum antibiotics while awaiting culture results. For Staphylococcus aureus, empiric therapy would often involve vancomycin or clindamycin depending on local resistance patterns. Septic shock management. If hypotension persists despite adequate fluid resuscitation, vasopressors like norepinephrine may be needed. A 22-year-old male presents with multiple small, hypopigmented macules on his chest and back. He reports that the lesions have been persistent for several months and are not painful or itchy. A KOH preparation reveals budding yeast cells. What is the diagnosis and how would you treat this condition? Answer: the diagnosis is tinea versicolor, a superficial fungal infection caused by Malassezia species. It presents as small, round, hypopigmented or hyperpigmented lesions, most commonly on the trunk and shoulders. The characteristic findings in the KOH preparation include yeast cells and hyphae, spaghetti and meatballs. Appearance. Treatment involves topical antifungals such as ketoconazole shampoo, selenium sulfide lotion, or clotrimazole cream. For extensive or recurrent cases, oral antifungals like fluconazole or itraconazole may be required. A 25-year-old sexually active woman presents with painful genital lesions, fever, and swollen lymph nodes. She is concerned about the possibility of a sexually transmitted infection. What are the key differentiating features between genital herpes and syphilis in terms of clinical presentation and laboratory diagnosis? Answer: genital herpes caused by HSC2 typically presents with painful vesicles or ulcers on erythematous bases, often associated with fever, lymphadenopathy, and systemic symptoms during the initial outbreak. The lesions are recurrent and often appear in clusters. Diagnosis: PCR testing or viral culture for HSV is the gold standard for diagnosis. Treatment: antiviral agents like acyclovir or valacyclovir are used to manage the infection, reduce symptoms, and shorten the duration of outbreaks. Syphilis caused by Treponema pallidum presents with a painless chancre ulcer in the primary stage, which typically heals spontaneously after 3-6 weeks. Secondary syphilis can manifest with a rash, mucocutaneous lesions, and lymphadenopathy. Diagnosis: serological tests like RPR, rapid plasma reagin, or VDRL, followed by confirmatory FT-ABS fluorescent treponemal antibody absorption test. Treatment: the first-line treatment for syphilis is penicillin G. A 35-year-old patient presents with periods of extreme mood swings. Over the past few months, she has had episodes of elevated energy levels, racing thoughts, reduced need for sleep, and increased impulsivity. These episodes are followed by periods of deep sadness, feelings of hopelessness, and lack of energy. She reports that during the manic episodes, she feels overly confident and tends to engage in risky behaviors. What is the most likely diagnosis, and what are the key diagnostic criteria for this disorder? Answer: the most likely diagnosis is bipolar I disorder. The key diagnostic criteria for bipolar I disorder, according to the DSM-5, include the occurrence of at least one manic episode lasting at least 1 week or any duration if hospitalization is necessary, in one or more depressive episodes. During a manic episode, the individual experiences a distinct period of abnormally and persistently elevated expansive or irritable mood and increased activity or energy. At least three of the following symptoms are needed: inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual or pressure to keep talking, flight of ideas or racing thoughts, distractibility, increased goal-directed activities or physical restlessness, engaging in risky behaviors, e.g., spending sprees, sexual indiscretions. The depressive episode often follows the manic phase, characterized by significant mood disturbance, lack of interest in activities, fatigue, and thoughts of death or suicide. A 28-year-old woman at 24 weeks of pregnancy presents for a routine screening for gestational diabetes. Her BMI is 32 and her previous pregnancy was uncomplicated. She has no family history of diabetes. What is the recommended screening method for gestational diabetes, and what are the diagnostic criteria for gestational diabetes according to the American Diabetes Association, ADA? Answer: the recommended screening method for gestational diabetes is the oral glucose tolerance test, or typically a 1 hour 50 grams glucose challenge test is performed first. If the result is 104 mdl, the patient undergoes a 3-hour OGTT with 100 grams of glucose. The diagnostic criteria for gestational diabetes, as outlined by the ADA, are as follows for the 3-hour OP: fasting glux equals 95 mdl, 1 hour glux equal 108 mgl, 2 hour glux equal 155 mdl, 3-hour glucose equal 100 or D. The diagnosis of gestational diabetes is confirmed if two or more of these values are met or exceeded. If gestational diabetes is diagnosed, management includes dietary modifications, blood glucose monitoring, and possibly insulin therapy if needed. A 40-year-old male veteran presents with flashbacks, nightmares, hypervigilance, and difficulty concentrating. He reports that he was involved in a combat situation several months ago and has experienced ongoing distress ever since. The patient avoids thoughts, feelings, and reminders of the trauma. Based on the clinical presentation, what is the most likely diagnosis and what are the diagnostic criteria for PTSD? Answer: the most likely diagnosis is post-traumatic stress disorder (PTSD), according to the DSM-5. The diagnostic criteria for PTSD include exposure to a traumatic event, directly experiencing, witnessing, or learning about an event involving actual or threatened death, serious injury, or sexual violence, intrusive symptoms, e.g. flashbacks, intrusive memories, or distressing dreams related to the trauma, avoidance behaviors, avoiding thoughts, feelings, or external reminders of the trauma, negative alterations in mood or cognition, e.g. feelings of detachment, inability to recall important aspects of the trauma, or negative beliefs about oneself, hyperarousal symptoms, e.g. irritability, difficulty sleeping, exaggerated start or response. The symptoms must last for more than 1 month and cause significant impairment in social, occupational, or other important areas of functioning. Mr. Reed, a 28-year-old man, is admitted to the psychiatric unit after experiencing persistent auditory hallucinations and disorganized speech. He believes that people are following him and that his thoughts are being broadcast. These symptoms have been ongoing for over 6 months. He denies any history of significant substance use or medical conditions. What is the most likely diagnosis and what are the key components of the treatment plan for this condition? Answer: Mr. Reed's presentation suggests a diagnosis of schizophrenia. The DSM-5 criteria for schizophrenia include 2 or more of the following symptoms, each present for a significant portion of time during a 1-month period or less if successfully treated: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior. Negative symptoms, e.g. reduced emotional expression or inability to initiate purposeful activities. The treatment plan for schizophrenia typically includes antipsychotic medications, with second-generation antipsychotics, e.g. risperidone, olanzapine, being the first-line agents, psychosocial interventions including cognitive behavioral therapy (CBT) and family therapy to address the social and psychological impact of the illness. A 30-year-old pregnant woman at 34 weeks of gestation presents with a headache, visual disturbances, and swelling of the hands and face. Her blood pressure is measured at 106 to 100 AHG and urine dipstick shows 2-proteinuria. What is the most likely diagnosis and what are the key management strategies for this condition? Answer: the most likely diagnosis is preeclampsia. This condition is characterized by hypertension 104 to 9 AHG and proteinuria 300 mg in 24-hour urine after 20 weeks of gestation. Symptoms such as headaches, visual disturbances, and swelling suggest severe preeclampsia. Management includes immediate hospitalization to monitor maternal and fetal well-being. blood pressure management using antihypertensive medications such as libitalol or hydralazine, magnesium sulfate to prevent seizures, eclampsia. Delivery of the fetus is the definitive treatment, with the timing depending on maternal and fetal conditions. If the condition is severe, delivery may be considered as early as 34 weeks, with the goal of preventing further complications. A 45-year-old woman with a history of unstable relationships, intense episodes of anger, and chronic feelings of emptiness presents for evaluation. She often experiences intense mood swings and engages in self-destructive behaviors, such as cutting. What is the most likely diagnosis, and what are the key features of this disorder? Answer: the most likely diagnosis is borderline personality disorder (BPD). Key features of BPD include instability in relationships, self-image and affect, impulsivity leading to self-destructive behaviors such as self-harm or risky behaviors, chronic feelings of emptiness and difficulty managing emotions, intense mood swings and difficulty with anger control, fear of abandonment, which may lead to frantic efforts to avoid real or imagined separation. Treatment typically involves dialectical behavior therapy (DBT), which focuses on emotional regulation, distress tolerance, and interpersonal effectiveness. Medications such as SSRIs may also be used to manage symptoms. A 34-year-old woman who is interested in long-term contraception asks about the benefits and risks of intrauterine devices (IUDs). What are the types of IUDs, their effectiveness, and potential complications? Answer: there are two main types of IUDs. Copper IUD, Paragard, a non-hormonal device that releases copper ions to create an inflammatory reaction in the uterus, preventing fertilization. It is highly effective with a failure rate of about 0.8% per year. Hormonal IUD, minor, Skyla, releases progestin to thicken cervical mucus and thin the uterine lining, preventing fertilization. The failure rate is less than 0.2% per year. Potential complications include expulsion of the device, rare; uterine perforation, rare but serious; increased risk of infection in the first few weeks after insertion. IUDs are considered among the most effective forms of reversible contraception, offering long-term protection. A 22-year-old woman presents with heavy menstrual bleeding, menorrhagia, and irregular cycles. She reports that her periods have been increasingly irregular over the past year, with some cycles lasting 4050 days. On examination, she has no signs of systemic illness, and her pelvic examination is normal. What is the most likely diagnosis, and what is the first-line treatment option? Answer: the most likely diagnosis is anovulatory bleeding, which is common in young women, especially during the first few years after menarche when hormonal cycles are still maturing. Anovulatory cycles occur when the ovaries do not release an egg, leading to irregular or absent ovulation. This can cause prolonged and heavy menstrual bleeding due to prolonged endometrial stimulation by estrogen without progesterone opposition. The first-line treatment for anovulatory bleeding often includes hormonal therapy, with combined oral contraceptives, COX, being the most common approach. COCS provide a steady level of estrogen and progestin, which helps regulate the menstrual cycle and stabilizes the endometrial lining, preventing excessive growth and shedding that leads to heavy bleeding. In cases where hormonal therapy is contraindicated or not preferred, progestin therapy, oral, injectable, or intrauterine, can be used to induce regular shedding of the endometrial lining. Tranexamic acid, an antifibrinolytic agent, and NSAIDs, non-steroidal anti-inflammatory drugs, may also be used to manage heavy bleeding, particularly in cases of mild irregularities. If bleeding is severe or unresponsive to medical management, additional interventions such as endometrial ablation or DC dilatation and curettage may be considered. A 24-year-old patient presents with a history of intrusive, unwanted thoughts of harming others. To alleviate these thoughts, he engages in compulsive checking behaviors, such as repeatedly locking doors. The behaviors are time-consuming and cause significant distress. What is the most likely diagnosis, and what is the first-line treatment for this condition? Answer: the most likely diagnosis is obsessive-compulsive disorder, or OCD, a condition characterized by persistent intrusive thoughts, obsessions, and repetitive behaviors or mental acts, compulsions, that the individual feels driven to perform in response to the obsession or according to rigid rules. In this case, the unwanted thoughts of harming others represent the obsessions, and the repetitive checking behaviors are compulsions intended to neutralize the anxiety caused by these thoughts. The distress caused by these symptoms, along with the time-consuming nature of the compulsions, is a hallmark of OCD. The first-line treatment for OCD includes cognitive behavioral therapy (CBT). Specific exposure and response prevention (ERP) is the most effective form of CBT for OCD. RP involves exposing the patient to feared situations or thoughts without allowing them to perform the compulsive behaviors, which helps reduce anxiety and break the cycle of obsession-compulsion. Selective serotonin reuptake inhibitors (SRS) medications such as fluoxetine, sertraline, or fluvoxamine are often used as first-line pharmacotherapy for OCD. SSRIs are effective in reducing the frequency and intensity of obsessive thoughts and compulsive behaviors. These medications are generally well tolerated and can be taken long-term. A 26-year-old woman presents with lower abdominal pain, fever, and abnormal vaginal discharge. She has a history of unprotected sexual intercourse and a recent episode of chlamydia infection. On examination, she has cervical motion tenderness and adnexal tenderness. What is the most likely diagnosis and what is the first-line treatment for this condition? Answer: the most likely diagnosis is pelvic inflammatory disease (PID), an infection of the upper female reproductive tract, often caused by Chlamydia trachomatis or Neisseria gonorrhoeae. PID typically results from the ascension of bacteria from the cervix or vagina into the uterus, fallopian tubes, and ovaries. It often presents with symptoms such as lower abdominal pain, fever, abnormal vaginal discharge, and signs of peritoneal irritation such as cervical motion tenderness and adnexal tenderness. The first-line treatment for PID is empiric antibiotic therapy, which covers the most common pathogens, chlamydia and gonorrhea, as well as anaerobic bacteria. A common regimen includes ceftriaxone for gonorrhea, doxycycline for chlamydia, metronidazole for anaerobes. Patients with mild to moderate PID can often be treated on an outpatient basis with these antibiotics. However, if the patient shows signs of severe illness or if they are pregnant or immunocompromised, hospitalization may be required for intravenous antibiotics and closer monitoring.